Sama kan mengenainya? Sama.
Right, let's start our seminar today. Good afternoon, ladies and gentlemen. Welcome to today's Micro-Economica Talks series, hosted by Micro-Economic Dashboard, Faculty of Economics and Business, Gadjah Mada University. Our topic today is about long-term health effects from short-term pollution exposure. We are honored today because we have an esteemed speaker, Mr. Nicolau Martin, Bassols Ph.D. Good afternoon, Mr. He is a research fellow at Center of Health Economics, Monash Business School. Today, he will share his study on the effect of severe pollution in utero and early childhood on respiratory health at older ages. He got a Ph.D. from Monash Business School, Center of Health Economics, with dissertation title Empirical Research on Health Economics of Aging. And his research areas are applied microeconomics and microeconomics. Today we have also Mr. Novatugo Sambodo as a lecturer at Economics Department, Gadjah Mada University, and today he is our esteemed discussant. Now he is a Ph.D. student at Erasmus School of Health Policy and Management. Okay, we encourage all participants in this room and in Zoom meeting to actively engage in this seminar by asking questions and also participating in our discussions. Before we start our presentation, let's have photo session first. So Mr. Nicolau and Mr. Hugo, please come to the center and all participants. Yeah, all participants in this room and also in this. Yes, foto dulu. Keeper there. Okay, thank you. Without further ado, let me invite Mr. Nicolau to present his presentation. You have around 40 minutes to deliver.
40.
Okay. Perfect. Thanks so much.
Thank you. Slides.
Yeah. Okay. Yeah, my name is Nico. I'm a research fellow at the Center for Economics of Monash University, and today I'm going to present you joint work with Sonia Deniu, David Johnston, and Michael Shields. And the title of this paper is Long-Term Health Effects of Short-Run Pollution Shocks. So basically what we do in this paper, we explore to which extent being exposed to a very intense event of air pollution in utero, one the man is pregnant, one in the gestational phase, can have very long-term health consequences. Just for the record, it's a condensed presentation, so probably some clarification will be useful at some moment. So please stop me if some questions. I also will maybe stop at some natural points of the presentation so the people on Zoom can throw in some questions, but just don't just always interrupt me, and I will try to do my best to respond as good as I can. For changing the slides, and now
Next slide. Yes.
sorry.
She will.
Change the slides. Okay. Yeah. Change. Okay. So just to motivate a little bit this topic, why is it important to research about air pollution? Basically, air pollution is one of the main contributors of premature mortality worldwide. According to the World Health Organization, air pollution is responsible for 4.2 million deaths worldwide, and it's been related with all types of causes of health, like respiratory health, asthma, COPD, pneumonia, but also circulatory health, and it's been related with nervous system conditions. So let's say it's a very, let's say like a prevalent condition, or cause for health conditions worldwide. And again, it's responsible for many premature deaths, but it's also very prevalent. And you can see from 2008 to 2013, there were 150 cities worldwide that they had annual levels of total amount of particles suspended in the atmosphere, TSPs, that were above 100 microns per cubic meters. And just for having some reference, this is 5 times what the World Health Organization considers as healthy levels. And basically, we are talking about these yearly averages, and these yearly averages are obviously kind of hiding some peaks of extreme pollution and let's say lows of less pollution, because we know air pollution is very dependent on meteorological conditions, on wind, on temperature, etc. So we have all this variability, in these pollution levels, and that's basically what we will be exploring in this paper related to this pollution in utero. Just a bit for motivation, I'm in Indonesia, so I noticed that Jakarta is quite polluted, but I think like the example that really sticks out is Jakarta. Found this newspaper article, I think it was something like Jakarta, the 3rd most polluted city worldwide. I have to say, like, I've been doing research on this field for years now, and I think like more or less for every city around the world, you can find this kind of statement, like in Melbourne. And at some stage, we were the most polluted city in the world because we had this bushfires in 2020. So my point is not particularly about Jakarta. Point is more saying like probably everyone in this room has been at Jakarta at some moment. There's probably some period also high pollution. So what I mean is the topic we are discussing here is very close to our. We've been at these situations of extreme pollution. We know what it is, and hopefully I can convince you with my data that actually these periods of extreme pollution can be very harmful for health, particularly at moments of development of extreme intensity like vegetation. So just let me put a bit of terminology. I guess we all have a basic knowledge of what pollution is. Just let me go to speed terms. So what is pollution? It's a combination of solid particles and gases generated from burning fuels on daily activities, industrial activity, and other natural processes. So basically, air pollution is let's say these tiniest substances that are generated basically from industrial activity, the consumption of burning fuels, but also of natural processes like mold, for instance. If you have mold at home, that's a type of air pollution. More relevant for this case, bushfires would be like a big cause of air pollution. And how does air pollution affect human health? Basically, this time we inhale these substances. Basically, the tiniest of these substances came back to the blood system, and then in the blood system they can cause oxidative stress to the cells, and this basically can cause lots of damage. And in the case of pregnant women, once the pollution is applied to the blood system, it can reach the placenta. Basically, there's been studies that have found that mothers that live in areas with high levels of pollution have higher quantities of particulate matter in the placenta, so this correlation can be found. And once in the placenta, basically the clinical literature has two hypotheses of how this could affect the fetus. Basically, this particular matter could create inflammation in the placenta, and this could damage the fetus. Or the second hypothesis, this particular matter could pass through the placenta and directly affect the fetus. This is still unclear in terms of the clinical mechanisms, but regardless of which the mechanisms are, we know that air pollution is actually harming the fetus. So first term, the fetal origin hypothesis. Basically, this is like this hypothesis that basically considers that if we would consider human development in a continuous way, since we are gestated until death, and we consider we are developing as humans throughout this process, the period with most intensity is the period of gestation, because basically our main organs and let's say all cells are being formed during the period of gestation. So any shock, any interaction during this period of gestation can have very dramatic consequences on all subsequent development. So therefore, this hypothesis argues that this period is extremely sensitive, and that any kind of shock experience during that period of time can have very long-term dramatic consequences. So in this case, we will be studying an event that on this paper we will be studying an event of extreme air pollution that occurred in London in 5 days. Where basically in a very short period of time, in a very also spatial kind of delimited way, pollution level arises in a dramatic way, and we will use this as a quasi-natural experiment to compare individuals who were born, who were conceived before and after this event, and in London and the rest. This event is the Great London Smoke of 1952. It was an event of extreme pollution that occurred from the 5th to the 9th of December of 1952. And basically what occurred, there was this cold weather waves in London, and basically individuals started to burn much more cool for their activity, and this let's say cold weather wave was accompanied by an anticyclone, which basically captured this active pollution above London, and created what they called at this time a very dense heat shock, a type of pollution like a kind of smoke, kind of yellowish, very dense, that had very dramatic consequences. And at the time, some sport events were cancelled. There were some traffic disruptions because this heat shock kind of really blocked the light and created like this kind of very dense smoke where people couldn't see at all. But overall, there was no big panic. And the reason is that you can see like Londoners were quite used to smoke. From 1866 to 1965, there have been 932 heavy smoke days in London. So basically, we can think Londoners were used to experience one heavy smoke day per year. So it was to some degree part of their normal. Big surprise, 1 week later, statistics report excess mortality of 4,000 individuals, which rise to 12,000 individuals in the following year. So a very dramatic picture, and this made really clear that this smoke event that they experienced, the Great London smoke, was nothing like they experienced before. It was much more dramatic in its consequences. It had a great impact in the society. The impact was so, let's say, so severe that it directly led to the implementation of the Cleaner Act of 1956. This was one of the most ambitious and most successful environmental policies ever implemented, and basically it reduced dramatically pollution levels in London. So yeah, these two figures, I hope, help you to see really the characteristics of the smoke in terms that it was very time and space delimited. If we focus on the figure in the top, you can see these are pollution levels in London during the days of the Great London smoke, the continuous line, and then you can see at these dashed lines, these are the pollution levels on the previous year. And basically, you can see, like on the previous year, you can see there's these average levels of pollution that are kind of similar in the pre-trend for 1951 and 1952. And then for the year of the Great London smoke, you can see this big peak that arises during 5 days, as I was saying, while the cyclone was trapping all these pollutants until the wind started blowing into London and kind of blew away most of this pollution. So as I say, it's very time concentrated. In terms of the space, whatever, not specific, these are the air pollution levels at 77 UK stations outside London. And basically, it's the same days where the Great London smoke occurred, and it's kind of nice. You can see this pretty flat line. So basically, you can see there was this peak in London, while the rest of England pollution levels remain more or less constant. So again, like time specific and space specific. And yeah, like it's always nice having a picture. I like this one very much to see what we are talking about. This is an image of the Great London smoke. You can see this is London, Trafalgar Square, and I think it's a very nice picture because basically you can see this extreme piece upper to the level that the street lamps are on during the day, because otherwise people couldn't see that there was not enough light. But what I like about the picture is mostly that you can see that even under this kind of dystopic scenario, people were more or less running their normal life activities. So maybe like if someone stop a minute, if someone has a question also in the Zoom or something like this. No question? Yeah, we can just. Okay. So where do we sit in the literature? So basically, we sit, let's say, different parts. Like as I was saying, there's been lots of work on regarding this fetal origin hypothesis. Basically, lots of papers studying the effects of stress, of natural disasters, pollution, on this, on the effects of gestation. Basically, we sit on this literature, that considers the effects of air pollution. But most of these papers have considered the long-term, let's say, the prolonged exposure to air pollution. So they basically consider the full period of gestation and consider fetuses that were, or let's say, babies that were exposed in the whole gestation to this higher level of pollution. In our case, what's particular, we look at a very short run exposure to air pollution. We're looking at these 5 days extreme air pollution. As I was saying before, we were talking whatever. Why this topic is relevant to all of us? It would be like even if we could be going for a couple of days, whatever, to Jakarta, and the levels of pollution would be very extreme during those days. That could be already very bad for health. So we're really delimiting it very much, and basically there's only been 3 papers that have considered this very short run exposure to air pollution. The three have looked at the gray smoke because I think it's a very nice, quite natural experiment. So others have explored it as well. And basically, it's the papers of Bardawak, Val, and von Hinke to explore the short and long run effects of the gray smoke on economic outcomes. And basically, Bardawak, they studied the effects of the gray smoke on childhood and adulthood asthma prevalence. And basically, what they find is that individuals who were exposed to the gray smoke, they were more likely to suffer asthma during childhood, but not during adulthood. We think they don't find these long-term effects because to finding long-term effects, you need lots of power and very, let's say, clean atoms. And they basically have a small sample, around 42 individuals exposed by the gray smoke in utero. And also they have a bit of an health outcome. They have some self-reported reports. So therefore, we think that probably they don't find these long-term effects. In the case of Val, he finds very strong effects on economic outcomes, basically on labor outcomes. Individuals who were exposed to this smoke, they were more likely to work less hours, to suffer unemployment, etc. Many different health, labor and economic outcomes are considered. And in terms of the health outcomes, he only considers cancer prevalence, and he cannot find these effects of exposure in utero smoke cancer. He only finds that exposure at age 1, once the baby is born already, could lead to more cancer prevalence. In this case, again, we think he probably does not have the best outcome when it comes to these health outcomes because he considers any cancer condition, and we know, there's many kinds of different cancer diagnostic. All of them, they have very different conditions. So we think probably it's not the best outcome. And finally, there's like a very recent paper of von Hinke, a working paper. We are trying to position ourselves with this paper because it's the one that's more similar to ours. And basically, he finds the detrimental effects of the gray smoke, of exposure to the gray smoke in utero on respiratory health, on education, and on cognition. So, what will we do in this paper? Well, so we use the UK Biobank. It's a big database for over 500,000 individuals of the UK. Age 40 to 69, and the enrollment was from 2006 to 2010. So basically, it's great data. It combines self-reported information, it combines administrative information, and also objective measurements, so objective health measurements. And we will be looking at respiratory health outcomes, and basically we have these 4 outcomes. First, admin data of hospitalizations that occurred from 1997 to 2020. So basically, we know if these individuals not sampled, they were hospitalized to respiratory health causes in those 23 years. So very nice data. Then we have self-reported information where they report if they ever were diagnosed by a doctor with other respiratory health issues. Then we also have self-reported information about the current consumption of prescribed medications for respiratory health. So if at the moment they are using any kind of medication that is related to respiratory health problems. And finally, we have spirometry measurement. Spirometry measurement is basically some objective measurement that measure lung capacity. So we have this kind of information. We combine this information with a factor analysis and basically end up with a factor that is standardized between 0, standard deviation 1. Let's say with higher values capturing worse respiratory health. And after sample selection, we end up with roughly 43,000 individuals and observations, of which 3,000 were born in London or in utero or 801 at the pregnancy. So what we do there, or what I hope I convinced you with, we have like lots of power, big sample with 3,000 individuals who are exposed to this event in great numbers.
Sorry, Nico, a second question with the data, just making sure. So this is a cross-section of data, but you mentioned the initial enrollment is from 2006 to 2010.
Yeah.
So is it like longitudinal or cross-sectional?
So let's say, so basically, from the easy answer is like we are using cross-sectional data from basically individuals participated in the study from 2006 to 2010. It's basically like we were recruited for the study during those 5 years.
So you mean you got the individual characteristics from those 4 years?
No, no, no. It's basically like whatever. No, we will be in this classroom. No, for instance, in 2006 in January you would participate, and in February you would participate. And like since it's like 500,000 individuals, they couldn't interview all these individuals at once. So it was over the 4 years, let's say, until we would whatever. No, pass through the study the 500,000 individuals in this classroom.
Right, and the outcomes that you're using is from 1997 to 2010.
Exactly. This is where I was saying like it's this one is like in the UK biobank. So the nice thing is basically you have the main study, no, the one that we put from 2006 to 2010, and then what you have all these kind of additional items that were added, and one of these items were these hospitalization data from the NHS, which is a panel and which was added to the individual.
So the individuals are the same, right?
Sorry?
The individuals are
Yeah,
the same.
yeah.
So you got like newer information from 2020 for the
Exactly.
individual who enrolled in the biobank system.
Exactly. And but basically, we are using it still this variable. Let's say we are using it in a binary manner. Basically, we're saying like for these 20 years, did you ever suffer a hospitalization due to this respiratory condition? Also, just to extend a bit, like if you are interested in the YouTube biobank, like you know, because it's great data. I love the data, and from 2010 onwards, they have followed many following studies. Like they started with online reviews, so you can really think about it like longitudinal. The only problem for these additional studies, there's lots of attrition, so you more or less end up with 1/5 of the sample, was still 100,000 individuals. It's still big numbers, but yeah, that's a limitation.
Oh, one more. So biobank is not part of the HBS data, right?
No, no, it's not that. No, it's completely yeah. So yeah, let me go to the methodology and just before I go, let's say, to the formula, very basic. I wanna just say we are doing a very basic canonical model. The only difference is normally in a different deep model. Now we would be interested in our treatment, no, like in this case it would be being born in London versus being born in the rest of England. Then we would have a post-intervention period, no, and then we would have the interaction of treatment time cost, which would be for would give us our causal estimate. In this case, our post-intervention period is basically individuals conceived after the Great London Smoke. So basically, these individuals, this post period would be our control time period, and we would consider this pre-period as the period where we are capturing individuals that were actually affected by the Great London Smoke. Maybe let me walk you through the graph because maybe that makes it clear. So basically, this is our time span that we're considering December 1950 to August 1956. The Great London Smoke occurred in December 1952. So basically, individuals that were born from December 1950 to December 1952, they were aged 0 to 1 at the time of the Great London Smoke. Individuals who were born from December 1952, the date of the Great London Smoke, until August 1953, they were in utero during the Great London Smoke. And as I was saying, individuals who were born after August 1953, they will conceive after the London Smoke, so they shouldn't be affected by the Great London Smoke. So I was saying, and therefore in this paper, we would be looking at this fit times free as the interpretation of the causal effect. You can see there's still these two lines. First one at March 1954. Basically, the literature has found that after national disasters or extreme events, individuals shift their fertility decisions. So basically, often they change the decision of having kids, no, in advance of the delay. That's a bit unclear according to the literature, but basically, we thought that this could bias the results. So we excluded, for sample, individuals conceived 6 months after the Great London Smoke. If you are uncomfortable with this, we have also run many other tests. We excluded 1 year, 1.5 years after the Great London Smoke. We did not exclude any of these periods at all. all these results always give us very robust results. And finally, you can see this line at August 1956. This was the date where the Clean Air Act was implemented. As I was saying, this was a very successful environmental policy. It diminished a lot air pollution levels, so we think it's also wise to limit or sample to this period of time. So in terms of the model, as I was saying, very simple. We have or Y or outcome or factor of respiratory health with higher values indicating worse respiratory health. Then, as I was saying, we have this treatment variable being born in London versus being born in the rest of England. Then we have or variable that this would be like year month per fixed effects. So basically, we have a fixed effect for each year month. And then we have this interaction of being born in London and being in utero or early childhood within the great London smoke. Basically, what I said in the previous slide was not clear. Just consider this beta 3. This is the interpretation of the causal effect of the great London smoke in utero or early childhood. And then we have this vector of controls X, where we basically include gender, and we include the age of individuals at the time of the interview, basically with each of the interview, most of the interview fixed effects. And you can see it's an almost fully saturated model, and the issue is basically since we are considering a shock that occurred at very early life, any kind of control that, or most of the other controls we would be including in this model would be probably endogenous to this treatment because we would already be affected by this treatment. So it would be, let's say, bad controls. Therefore, it's a very saturated model. So this is the main table of results. You can see it's divided into panels and several columns. Let me walk you through it. Basically, two panels. We consider exposure to the great London smoke in utero, H0 and H1 in panel A. Panel B, we focus at the period of gestation, exposure in utero, and we consider if some particular period of gestation could have been more vulnerable to this pollution shock. And then you can see there's these 5 columns. Basically, we have first column, the total sample, and then we stratify all results by gender and socioeconomic status, where individuals were born. So if we focus on panel A, column 1, you can see that being exposed to the great London smoke in utero increases the probability of suffering worse respiratory health issues, and 0.08 standard deviation. Significant when we look at the coefficient below. Being exposed at H0 also increases the probability of suffering worse respiratory health problems by 0.1 standard deviations. And when we look at exposure at H1, this coefficient diminishes by half and becomes not significant. So we can see this very large effect for the exposure in utero and H0 to the London smoke. And then it seems like this effect becomes much smaller, very close to 0, and much more noisy, non-significant. So big effect for exposure to great London smoke during those periods. When we look columns 2 to 5, stratifying the results by gender and socioeconomic status, it's quite clear that the effect is mainly driven by a male who were born at low SES scores. And these results we find exciting because, I think they're very insightful, and basically they have to be interpreted carefully. First of all, why do we find these results for male and not female? There's like some clinical literature that suggests that what they call them like male frailty, that male fetuses are more fragile than female ones. And basically, the main idea is that since male tend to go bigger than female, when there's any of these kind of shocks that could lead to disruption in oxygen or nutrients, the male would be affected more by these in utero shocks than female.
This for clarification, socioeconomic status is variable that you use because I haven't seen model.
Basically, we look. It's just a proxy. As I said, like it's a very condensed presentation. So I went a few things. It's a very good question. So basically, we look at the 10 years after our sample finishes, like basically April 1956, when we look at the average years of education at the different boroughs of England and London, and basically we boroughs who have like higher, more years of education, of average education are considered highest years, while boroughs with lower highest years of education are considered lower years. So it's a proxy, but I think education as a proxy of SES is a quite better proxy. Yeah. So yeah, sorry, I was explaining why we find these effects mostly for SES male, and I explained why we think they're finding this effect for male. When it comes to this SES gradient, the first thing that came to mind is basically maybe this pollution discriminated by SES. So basically, this pollution was much worse at other areas of London. Maybe these areas are more industrial and whatever reason, and therefore pollution levels are higher at these areas. We looked at some registries of the time, and basically we couldn't find any kind of correlation of air pollution and richness, no, or CS level at that period of time. So that seems an unlikely explanation. We still could think that maybe richer, whatever, higher CS mothers at the time, they could stay at home, no, or maybe lower CS mothers would have gone to work even when pregnant, and that would have exposed them more to the greenhouse smoke. But yeah, seems to be maybe an insufficient explanation to find this very strong effect, no, on these low SES individuals. So basically, the other explanation we think about is that probably high SES individuals have a better capacity to identify and to treat the respiratory health problems of their children. And that's, I think, also a very, let's say, interesting result. I will suggest that even though individuals who suffer these shocks in utero, there's still scope to mediate these effects, no, and with their brain. Then this was about panel A. When we look at panel B, we are disentangling this effect by trimester of gestation. Basically, you can see if you look at columns 1 and 2, the effects of the Great London smoke were strongest at the first and the second trimester of gestation, no? Like at the first, they become very clear when we look at the total sample. When we look at this lowest CS male, it's the first and the second trimester of gestation. So for sure, the first trimester of gestation seems to be concentrating part of this effect. The second, maybe as well. And basically, the explanation for this, again, when we look at the medical literature, is that the lungs develop in very specific phases. I don't mind having much details of these phases, but basically, some of these developmental phases of the lung fit very well with these first and second trimesters of gestation, and as such, it seems that these phases of development would be more sensible to pollution exposure. We also found this effect at age 0, just to say the development of the lungs does not stop, I think, until the second year of life. So we could also think that once the fetus or the baby is not more protected by the placenta, we again see these stronger effects for pollution in utero. Yeah, so that's how we interpret these effects. And basically, yeah, when we look, we found these effects that we are interpreting as the causal effect of Great London smoke, and like most different in the identification strategies, we have to justify that they are not driven by, let's say, different, in this case, we are post-trend, non-existent post-trend. So basically, what we are doing in this graph, we are comparing individuals who were born after the Great London smoke with individuals who were exposed to the Great London smoke. So basically, if we focus at the left side of the graph, the interesting part, we are comparing individuals who were conceived, let's say, right after the Great London smoke. This would be a baseline, with individuals who were conceived a bit after the Great London smoke, individuals who were born much after the Great London smoke. No, you can, difficult to read, but it's individuals born 15 to 23 months after the Great London smoke, 24 to 32, and 33 to 41 months after the Great London smoke. While on the right side of the graph, we see exposure in utero, these 3 dots, and then age 0, age 1. Basically, moving again to the left side, this is the interesting part. You can see being the baseline category, no, like being conceived just after the non-smoke, there's no effect for the following periods, no. These coefficients are very close to zero and they are not significant, so it seems that our effects are not driven by a post-existing trend of the case. The contrary, these results on the right side, basically what I already exposed in the previous slide, you know, like this effect, strongest effect at the first and the third station, and then part of this smaller effect at H0. So, also this is, let's say, the main paper, like from now on, if you want to interrupt me, stop me, or whatever, like that's the main objective of the paper is done. Now, I could run you over many robustness checks we've been running. I would convince you once and again that our results are very robust, but I find it's more interesting. I would walk you through 3 figures if I have some time of new results that we're running, where I think we are finding still some additional hints to this paper that I do think make it a bit more exciting. This first table here is at the moment where we are trying to base our new line of this paper, because as I was saying, there's the new paper of Valentino, which we are trying to position ourselves. And basically what we did, so I was saying at the beginning of the presentation, in this station, all organs are developed. We are basically developed as humans, so we could be kind of agnostic on which health conditions should be affected by pollution in vitro. We started choosing respiratory health because it's been the outcome by which I have received more attention by the literature so far. But what we do in this graph, we did a scoping review, and we look at all the literature in this field, and we look at which outcomes have received attention so far. So basically, the outcomes that have been explored when we were looking at this literature on pollution and exposure in utero, our respiratory health, circulatory health, neoplasms, mental health, and nervous system conditions. So what we did, we took our variable of hospitalization and we created variables that consider being hospitalized by any of these 5 conditions, these most prevalent conditions considered in the literature so far. And we introduced these variables in separate models. So you can see these different dots. They are the coefficient of the causal effect of the non-smoking utero for each of these different conditions as a different outcome in each model. And I think what's quite exciting about this figure, you can see the topper dot or the result I just showed you, this strong effect for respiratory health. But then you can see these very close to zero coefficients, very noisy coefficients for the rest of the outcomes. So I think this is a very interesting result because most of the literature has found effects for all these 5 outcomes. In all scenarios, with all data, we are only capable to, let's say, replicate these results with respiratory health. I think this is very interesting because this has not been basically done before. Like all the studies always consider these outcomes individually. For the first time, we really consider from the same data, the same scenario, all the potential outcomes that could suffer from this kind of event. So the second result that we found interesting, basically the idea was it's a very different story if we think about individuals starting to suffer as of basically respiratory of older age, or we have a database that basically considers older age individuals. It's a different story from saying individuals start to suffer respiratory issues at very young age, and they carry on with these problems during their whole lives. So basically, we found that this variable of self-reported respiratory health problems that also ask individuals when it was the first time when they started suffering these respiratory health problems. So basically, we have these outcomes for diagnosis before age 20, before age 30, before age 40, and 50. And what you can say basically is that we find a strong effect for being diagnosed before age 20, but also for the second trimester of gestation for age 30, 40, 50. So basically, all results would be suggesting that individuals started suffering these respiratory health issues at a very young age, and they carry them on until older age, what's obviously a much, let's say, worse, no, severe effect of this. Yeah, finally, last slide of results that we'll go through. We were thinking a bit about the mechanisms of this. It was basically, I was showing what was suggesting in the research in the beginning. It's been found that this smoke effect, or we find this smoke affects respiratory health, but it's been found that it also affects labor outcomes, that it affects education, that affects cognition. So it remains unclear, so to some extent, if the smoke directly affected individuals in vitro, their respiratory health, or if maybe, for instance, let's say for the sake of the argument, it affected the cognition, and this made them change some lifestyle decisions, which, for instance, in this case, made them smoke more or take on risky habits, which on its own led them to suffer worse respiratory health issues. So what we do in this table, basically, we see if the smoke was predictive of risky conditions or lifestyle-related conditions that could have led to worse respiratory outcomes. So we look at these 4 different outcomes. First outcome, we have the location where individuals are born. We match this location with MERA2 data, it's the incremental data of NASA, the test levels on the PM2.5 particulate matter, and basically we take yearly average pollution average, yearly pollution average levels on the place of residency of individuals. No, the idea is basically, no, if you live in the area with worse pollution levels, it's likely that you will suffer more respiratory health levels. Second variable, UK Biobank provides information about the traffic intensity on the place of residency of individuals. So we also have a similar reason, no? Areas with more traffic intensity will be more polluted. We also consider this variable. Then we have information if individuals ever smoke. And finally, we have information about the labor lives of individuals, so which occupation they held. We match this information with PostNet data. PostNet is a database that basically has information about the characteristics of different occupations, and specifically we look at occupations that involve being around many pollutants. So we have a variable node that captures in an occupation with high levels of pollution. So basically, when we run all these 4 regressions, we overall find very small effects. They are inconsistent. You can see these positive, negative signs. Most of the results are not significant. The ones that are significant point at the contrary direction of what we would expect. No, looks like individuals look exposed to green and smoke would live at least less polluted areas or have occupations with lower pollution levels. But overall, what we conclude with this table is that we're basically finding noise, and as such, we cannot have a big stand, no, or these results don't support the hypothesis, no, that this smoke was led to lifestyle conditions or other factors, and we would still think that probably the smoke affected by that very effect on respiratory health in general. So yeah, let me wrap up. Like I normally don't, for such a short presentation, I don't like to make a summary, then just go to the discussion. And basically, this paper has 2 very different interpretations for the discussion, or 2 different conclusions. First conclusion, in the scenario of developing countries, we know that the pollution levels experienced in the greenhouse smoke type of pollutants are actually very prevalent and big negatives in developed countries. So we know that events of these magnitudes are occurring at this moment at these negatives. So seems like obvious now we should protect most vulnerable individuals, in this case fetuses in vitro, from these events. And I think like the first way to do it is managing to have good data on air pollution to be able to signalize people to protect themselves in this event. And basically what the literature suggests is that often data in these countries is low quality, insufficient, and often even corrupted. No? So in this case of developing countries, I probably like the conclusion would be like we need more and better data to protect these individuals. The case of developed countries, it's a bit different because an issue of external validity. Like this smoke, basically, the literature suggested that was very, let's say, detrimental because there was a lot of sulfur dioxide among the pollutants who emitted. Sulfur dioxide under the right conditions can transform these very tiny droplets of sulfuric acid that will melt, according to the medical literature, can be extremely detrimental. This is rarely to occur in developed countries because sulfur dioxide normally occurs from the burning of unpurified fuels, and these fuels are not normally highly regulated in the case of developed countries. Still, in the case of developed countries, that can occur natural disasters or extreme events, like bushfires, which need high levels of clear particular matter. As such, our conclusion would be for this kind of scenarios is that further research has to determine if these effects we find pollution in vitro differ due to the type of pollutants that are. So yeah, thanks so much for having me here, and yeah, excited if there's any more questions.
Yeah, thank you, Dr. Nicolau, for the presentation. Let's give applause for him. Okay, our next session is the comment from the discussion for Pak Hugo. The time is yours.
Okay, slides.
This is the Pak Hugo's slide.
Okay. So you said the question for maybe after this we have a
Yes.
question, right? For Nico.
Q&A.
Because this is the stage for Nico.
Yeah. Please,
Okay.
Dr. Hugo.
Can you share my slides just to guide me on discussion? Is it done? Okay. This is a nice presentation, Nico, on how you capture the smoke in 1952, right? 1952 in London. It is such a privilege for the developed countries to have such a nice data like the UK bank. So today I would like to share my experience. Actually, the one of my PhD chapter is on the back of the forest fire in 2015. Indonesia, and so that's why I brought up the title of challenges and opportunities on the research and climate change in using Indonesian case. The next. Okay, actually the topic in climate change and the impact on health and economy is also and other topics. Other fields is increasing, like the thing over a recent paper. We can see that the number of articles talking about the climate change from the 1970, right? So it's upward trend. Okay. Oh, what is before climate change research aims to understand global environmental change and how it impacts to the nature and society. Okay, and now they are increasing number of articles. Maybe hopefully soon from Nico. It's already published.
We are we just got a rejection. So we are
that's part of the story.
part of the story.
Next, but in all of those articles, actually Indonesian every of our developing countries present is not so much. There are only few. Maybe we are not in the list. Maybe only India, right? That have research on climate change. Most of the publishing countries are from developed countries, like UK and United Kingdom, like Nico doing now is on London and United States. United States was prevalent maybe in California or something like that, and then maybe in Australia, we know that bushfire. I mean, but actually, we also have a forest fire every decades. We have a big fire, forest fire in 1997, and the latest is 2015. But you can see that there is a few papers published from Indonesia. Yeah, so we are still have because a lot of you guys, the young Indonesians, should be take a look, and then we need to make more research on this, because maybe it might not you affected by this climate change, maybe your kids and your grandkids. Okay, next. And the keywords related to economic, business, and finance are limited, mostly more on environment, or on health, on science on it, but not only few on policy, for example. And yeah, but it's not for the next, not from the business and economics. So you can see here, oh, in the PGP should be here. I don't know. Number of research articles in business economic on the climate change also small compared to the environment that I mentioned before, and nature. So business and economics, very small articles talking about it, about the climate change. Next. Even this is because some of the researchers cannot see people from the researchers from Indonesia have collaborated with others on the climate change. You can see this maybe for Asian countries like India, maybe Singapore, and maybe in Malaysia. Because in Singapore, maybe because they get the age from us, so a lot of research on the climate change is coming from there, and also for the but not so much in Japan, and but not from even China. Yeah, I read a lot of paper from China, but Indonesia, not so much. Next, this maybe therefore is what you see the maps of the networks from this. It is also need for more collaboration with the other researchers from the other countries. Okay, for the great challenge in the climate research, as I mentioned with the last slide from Nico, one of the challenge is like the access to the data for climate research. Indonesia, we have we call it Badan Meteorologi Geofisika. It's like meteorological body from Citizen of Indonesia, but you cannot see like the daily, like PM 2.5 or PM 10 or the air quality condition daily is there, but it's not accessible for the researcher to like really. So we have a lot of bureaucracy to get the data, and also we don't have like, I'm not sure, we don't have like the act, but for example after this London swap, and then they have like a lower like act to control the air pollution in Indonesia. We are not that strict on the, okay, people can live with that level, but it's not acceptable because the cost of the cost of how the pollution is really high, but we haven't measured it in a proper way. Okay, so one of the again the challenge about the access of data. Okay. And we also have a challenge in communicating with the climate skepticism, and even for the policymaker in Indonesia. So it is necessarily increasing to communicate clearly to the Indonesian audience what are the current states of the air pollutions and climate change, and one of the so why I call it great challenge and opportunities, because actually we have a lot of challenges, but we also have opportunities. We have across the land of fire. We have many. Well, I don't know if you call it what is it, blessed or not for researchers, because we have a land of fire. So we have a volcanoes, we have a tsunami at some point, we have a forest fire, we have a flood. So a lot of climate change shocks we see in Indonesia. So a lot of few, but only few paper talking about it, about the natural disaster in Indonesia. So now why is only few paper talking about the natural disaster in Indonesia? Because they exist for the data in climate research and natural disaster is limited. Next, but again about the access data. Some of the what is the types of research that we can do with the existing data. Now, you might know the Indonesian Family Life Survey is the some of the longest, I think, the longitudinal data that we have. They are not only a few people that can access it because it's quite complicated data. But in terms of the data that available, maybe only our neighbors have it. For example, this is the American Economic Review paper from Southern and Taqy. I think that this is the case of Singapore. Why? They have the data of the clinics, and they have every village, not village, but I don't know how the level of the administrative level in Singapore, but they have every every community has one of the ground stations to calculate the PSI or the air quality conditions. So they have it, and they have the weekly report on the clinics. So when the forest fire happened in 2015, so they get haze from us. So we are a good neighbor giving the haze, bad neighbor giving the haze to them. So they use the IP the two-stage risk square, because they start from the forest fire, then get the smoke level, the pollution level, and then they try to get the impact on the clinics. It also happened in Malaysia, our neighbor as well. They have the data in Malaysia. Happened in 1997, and again they try to get what is the impact of the 1997 forest fire in Indonesia, impact on their health, because they have the access for data. Next, but there is always a way. With the limited of data, still we can make a case. For example, the Fragenberg and the Taqy and the Monash, they working with the IFLS. This IFLS is start from 1997, 2007, and then 2014. But this is I think the second wave, because 93 and 1997. They try to see the impact of the 1997 forest fire on the during the activities and general the result for respiratory and general health. But this is like more on self-reported health. So yeah, but it's still acceptable at the time because there are not so much information we have at the time. But with this one, the air quality and early life mortality, they're using the census. So it total again with the 1997 forest fire, and the Jaya Chandran, I think from Secret Word, if I'm mistaken, they try to make make a case that it will impact on the mortality of the kids using the census data. So that's what we have. And this one again from the Singaporean. No, Maria Rosales is from the US, but Margaret Triana is Indonesian, but research from National University of Singapore. The persistent effect of early life exposure to alcohol. Maybe it will be the same with the Nicolau, not the approach, but with the longer term impact of the alcohol. Next. But I think one of the progress in Indonesian, especially for health data, is one of the because we have an Indonesian NHS or BPJS Kesehatan, because we have a BPJS Kesehatan, and they have a reform like they open the data for 1% sample, 1% sample. So we have around 1.7 million records. So we can get a cohort from 2015 to 2020. So we can follow this individual healthcare use, okay, in 5 years. One of the researcher from Manuel Fritz is from the Bassols, German. We try to get the temperature and communicable disease, non-communicable disease like cardiovascular, if I'm mistaken, yeah, from diabetes and cardiovascular. So they have an association if they are really hot days in Indonesia, like now, it's really hot, and then how it will have a consequences in a diabetes and cardiovascular. But just published in last year. So we have a improvement in data actually. So we also have difficulties in data on temperature. So that's why a lot of now research in developing countries using the satellite data. So the satellite data, because you are an economist, you might not have a capacity on trying to get the data in the right manner. So we have so you need to collaborate with the other with the other researchers in other fields, like from people from the geography or people from the environmental science. And in my case, although because we are the economist, sometimes we don't know the mechanism of how these pollutions goes to the people affected to health. Maybe Nico already said on in the beginning how cited some of the how the pollutions goes to the blood and etc. We are economists, we are not trained on doing it. So that's why if you are not doing the research, maybe you have to consultation with the people who are in the medicines, medical faculty, or maybe and do it for the climate variable. You can ask for people from the geography or environmental science. That's what I'm my suggestion because it took a lot at the beginning, so I'm doing it by myself. So if you want to do it in the future for your thesis, attributed thesis, you might need some help on that. But it's really, I think at first, my first slide is the timely discussion, and it's related to yourself because you are living in a very vulnerable regions. Indonesia is very vulnerable, and also it's about your future. The climate change about our future. Okay, thanks. Okay, that's the last remark for me. Thank you. We will discuss in the question and answer.
Okay, give applause for Bugo. Thank you, Pak Bugo, for the overview by presenting some papers to us. Now we move to the next session is question and answer session. I will invite the participants in this room and also in the Zoom to ask to the Mr. Nicolau. Please, who wants to be the volunteer for asking? Perhaps in the first term, I will open for 2 or 3 people. Please. Yes.
Yeah, you
Yeah, okay.
microphone.
Okay.
Okay, first of all, thank you, Mr. Nicolau and Mr. Pugu for the presentation. And I want to ask Mr. Pugu first, how do you ensure that the outcome variable, namely respiratory problems, is explained by variables in models such as being born in London and exposure to weather disturbance, and not due to other characteristics, especially in long term. There will be many other factors that affect respiratory health. So that's my question. Thank you.
So basically, if I understand correctly, the question is how we rule out that it's really like we are capturing the causal effect of the smoke and not other subsequent exposure throughout the life of individuals. No, so I think like this is like again the biggest challenge, like as an econometrician, always trying to identify really this effect of the type of shock or intervention you're trying to capture. In our case, that's why we are, for instance, exploring in a lot of detail this event of the Great London smoke. I tried to make an argument at the beginning of this event being very, let's say, specific in time and space. So basically, since we are comparing these individuals who were born in London during the Great London Smoke, individuals who were born after the Great London Smoke and outside England, in other regions, we are kind of suggesting this was like, let's say, like an experiment. It was basically these individuals who were in the rest of England and who were conceived after the Great London Smoke, they're actually similar to each other, and the only difference that exists is that some of them experienced the Great London Smoke, some of them did not. As said, this is this is the challenge of an econometrician. No, there could always be other factors. We think that our identification is quite strong because we cannot think of many of them. For instance, we could think for instance, a challenge would be it was like, as I was saying at the beginning, there would be panic during the Great London Smoke, and therefore people behave in a very there's a lot of stress, and this stress actually causes the effect of the Great London Smoke. We've done research, we've looked. It seems like these type of events were quite common in London, so we think that individuals did not suffer much stress or panic. It was more or less part of their normality. Could be that actually we are capturing low SES status if as I was kind of suggesting, the smoke was much more intense in areas that were more poor, no, because they were more industrial. We go back to the records of the time, and we cannot show basically that such a, let's say, discrimination of the levels of smoke did exist. So basically, I think our work as econometricians is trying to find this neat identification, and then trying really to to look under all these potential stones and see, like, could it be this? Or no, that's not okay. Could it be this other factor? And I think that's more or less what is in the paper. It's a longish paper, but yeah, I think that's pretty much the most difficult part of the job. So it's a very good question.
Yeah, I think following from that question as well, I was wondering if you also control or, looking at the migration factor, because during those disaster, people might be panic, and then even if they were born or when they were 1 year old, they live in London, and then the family move up at London due to disaster, wouldn't that affect the duration of exposure to the smoke?
So basically the question would be, like, for instance, if I understand it correctly, if, for instance, like after the smoke, individuals decided moving outside of London, and as such, let's say, our population or control group is different from our treatment group to some degree.
What I understand is that you select your sample based on those who were, when they were in 2 year old or when they were 0 or 1 year old were in London.
Yeah.
But then what if when they were 2, they move up at London, because you selected from the data bank or from your data set only those who were born or when they were at most 1 year old was. That's my understanding.
So I think there's two things. Like, if it's individuals who were exposed to the Grey London smoke who moved outside London, I think that shouldn't be as problematic, because, for instance, this would be part of the mechanisms that I was discussing. Like we had this last slide of mechanisms. We are still finding for this sample that they are suffering worse respiratory health issues. And it could be driven because of this. For instance, they move outside London to more rural areas, and exactly to a rural area, and therefore the levels of pollutions would be less intense. The only thing I can say, we've tried to go this path, with the last slide of results I was showing of mechanisms. When we were looking, for instance, the average levels of pollutions where this current individuals live, we couldn't find much in these terms of pollution. We could look, and maybe that's a good idea, if there's actually a correlation on their current address and their address of where they were born. So basically, this is probably to check out. The second issue that could also occur, I think, related to what you're suggesting, is that individuals, not the ones conceived to the Grey London smoke, the ones that were that the Grey London smoke actually led for people to move outside of London. And this could be more problematic. I actually was thinking more about this one just when you were asking. It's a very good question. And I would assume in such case, probably it would be, let's say, probably the richer individuals who would have capacity of migrating related to the pollution levels. And I'm just now thinking how this would affect our individuals. If our control group would be composed by, let's say, poorer individuals who by definition have a worse respiratory health. So I think to this extent, this probably would lead to an attenuation bias, because basically we would be comparing let's say more wealthy individuals, to less wealthy individuals. Not sure if I'm right, but I will think about this one. It's a very good question.
But just making sure though, so for the first mechanism of the yearly average at residency, it's the current.
It's the current residence.
It doesn't have to be, they might not born in the current residence.
Exactly. It's the current place of residence. But actually what I was saying, a good thing that we probably should do is look again if there's like a correlation of the place where they were born, or also let's say migration correlation. If individuals were more exposed, were born to the at the time of the Great London Smoke, migrated more to other areas, and the individuals who did not, because that probably would answer your question, and that's probably that.
Information about the place where they were born. And
Yes, there's both. So this probably could just be, I could just run this kind of correlation, and but this probably would answer your question.
Thank you.
Also, I will do it.
And also maybe to Pak Pugo, Mr. Pugo, so I think most of the audience in here are students, like undergraduate students. I mean, most of them are also from my development economics class. So the issue of health economics, we did discuss that, but like in correlation between health economics and environmental economics is very rare, and not to mention data availability that you mentioned. So just in case, one of my students, perhaps those who are coming in here interested in those issues, can they come to you?
Of course. Actually,
Connect with Nico.
yeah. Actually, we have a contact with the Jakarta Province office. They have actually like a data on the because Nico's already showed the Jakarta is the most polluted cities, but we actually they have a data on what call it? I don't know, like only 10 house, and they record of the healthcare use. So it is they have a plot at some point, so maybe have a stop on that, and also they have a maybe shot on a temperature maybe, or on a pollution. Because I think Jakarta is a lot of every but actually they have a lot of stations on air quality station. So if you can combine that data, it's they are biweekly or I'm not mistaken. So you can compare the biweekly data and then see how this impact on their healthcare use or their health condition, for example, like maybe a lot of communicated diarrhea, but it's not related. But I cannot mistaken some of the data is in there. And secondly, about the national health insurance data is available free with the request to BPJS Kesehatan. So it's underutilized at the moment. So if you have a good research question, you can come to me, and then maybe you can I can be provide under maybe to Isha, because I cannot provide at the moment. So it's really a lot of opportunities on the combination with the health economics with the environment and natural disaster.
Okay. Yes. Nicolau. Please.
First of all, thank you, Mr. Nico and Bapak Bugo, for the great and insightful presentation. I would like to, I have some question from two questions to Mr. Nico. For the first question, given that the data used in your research and your research come from some reported and clinical measurement of respiratory health. And my question is, how well do these measures capture the full range of health impact associated with population exposure, and what potential bias could arise if sometimes outcomes are under report of this report. Sorry if I have missed if I have missed the presentation before. And the second question, maybe related with Mr. Hugo. The question is, given that the negative impact of in utero exposure population, what policy interventions could be implemented to mitigate this proportionate burden of population related conflicts on lower income communities. Thank you.
Yeah, I'm very sorry, I didn't understand the question. Like, would you repeat it? Like the question for me, like without the mic. I think there's like a bit of echo, and there's like, yeah. So what's the first question for me?
How well do this mission capture the full range of health effects associated with pollution exposure, and what potential bias on your research? If I have any specific.
So what was the first? How well did the?
How well do your research capture?
My outcomes. My research measures. You mean my health outcomes, no? How well they capture my.
How well they capture that full range of health effects.
Health effects, like respiratory health effects. So, like if I understand, like if how well like my respiratory health outcomes are basically capturing also respiratory health issues. So yeah, I think as I was saying at the beginning, like the researcher, I think like this is always the thing, no? Like always when you do research, the data can be only be as good as it can be, it can always be error in many parts. I do think that in our case, we probably have the best respiratory health measures that have been ever used. As I was saying, we are combining admin data from the NHS, which is basically the register that they have in the system with self-reported data, individuals on several measures, with objective spirometry data, basically this lung capacity. So I do think that to some degree, like obviously we will still think there could be some error, like with everything, but probably I think we are probably like capturing respiratory health in the best manner it's been done before. Yeah, but yeah, there's always scope to some error, no? So.
But that's different in, I don't know in the culture in the UK within Indonesia, because we are going to the hospital maybe after the damage is there.
It's already
done, and then maybe if they are in a more educated community, would be right away go to the hospital, right?
Also, in this case, like I think first of all, like, the NHS is public, so I think this probably wouldn't be such a problem in the UK context. Second, I think regardless if individuals are going to the hospital once the damage is high or low, we are just capturing respiratory health problems. We could be capturing severe respiratory problems or only mild respiratory health problems, depending on that. But in this case, again, it's like a proxy for respiratory health. It's even like we are doing this combination of different measures, So again, we are not. Also, this is always the thing, like the difference if you're doing a paper for people in medicine, where they very much like this outcome, where they exactly know what's happening, if it's whatever spirometry, they want to really have this whatever FDT or these ratios on lung capacity, or if it's economics, where we are more interested in the identification, and in this case, for instance, we are trying to maximize the power with being able to identify the effect on the long run. So again, like in our case, it's just a proxy, but I think given that we're combining all this information, we managed to get a lot of power and capture these long-term effects. But again, it depends. So there's no right or wrong. It just depends which audience you are trying to address.
Okay. Thank you, Taqy. Is there any feedback from you or Ina? Cukup?
Okay, the second question.
Okay, about the policy, I think Nicolas better answering the question on the website. I didn't have background or research on this. But I think it is good to know for the policymakers the impact of the impact of for example, in the case of forest fire in Indonesia, it's also effective in the people who are in the early life. When they are estimating the consequences, it's really high compared to the investment that they can go for example, for primary healthcare. Because our primary healthcare, because our primary healthcare is good in every village in Indonesia, but they are not. They are heavily burdened. They are low paid. They are less capacity. So it's better to prepare every El Nino or every before the drought or the dry seasons. They have to prepare for the expecting forest fire, for example, and also, yeah. The thing is, for example, forest fire, there will be fire, and the fire happen because there is forest, and the forest always be in the rural area, will be very far from the city. Can expect that people, but this case in Indonesia, people not keen to go to the hospital in the city because maybe it's like 7 hours with the car, maybe crossing the island. A lot of so I think for the next in Indonesian context, we should invest more on a primary healthcare service in the rural area, in the maybe at the outer islands, etc. But for the cities, I think they are more now Indonesian. Tourist the big cities for Jakarta, maybe Bandung, Surabaya, especially Java and Bali, they are better off. But for the islands in Sumatra and Kalimantan, they are less. The primary healthcare is less. What is it? The readiness is very low. So in the next future, if the climate change is getting worse, and the expected forest fire will be most frequent, we have to prepare that. And again, that's for the healthcare preparations. But again, how to prevent people who are burning in slash, the burning the forest is also one of the things. But some of the people from the Australia, from the ANU, try to make a experiment. If I give you money at some point, do you want to not burning the forest? But still it doesn't work. So there's still a lot of things to handle on that side. So again, people have to stick. People who are to burn the forest should be get the punishment, but also we have to prepare in the case of that still happen. I think that's right. Maybe Nico can add something.
Look, if I can add something, I'm not, let's say, I'm a researcher, I'm not a policy maker, and no, my point is more like I do think for instance, what we try to contribute with our paper is that I think it's quite established that air pollution is bad for whatever human health, but I do think for instance, if I can highlight something for a paper is basically like even very short periods of pollution are very bad. What does it mean? Like in terms of policy implications, there's always, when we talk about air pollution, there's always the problem that we know air pollution is bad, but on the other hand, air pollution is completely linked to economic activity. Exactly. So it's a very difficult topic because it's to some degrees like the needed bad. No, in this case specifically in our paper, for instance, what you're saying, look, there's a very let's say cost-effective policy you can do. It's basically during very short periods of time protect the most vulnerable population. So I think this actually has lots of policy implications because again, we are not just saying the obvious that air pollution is bad. We are actually suggesting that even though air pollution is bad, there's a way on how to minimize this harm, protecting the most vulnerable in the worst moments of time. And more generally, like I do think like in research, like I do think like that's often like also, or when I see good papers published, that since there's so many students, like maybe like this is like my opinion on sometimes what's like good research is like the questions are very specific, because these very specific questions often give much more information than once again like whatever, no, like finding correlations and the obvious whatever, no, risk factors that 100 times have been already studied, but these very kind of specific questions can be probably more relevant policy.
Nice discussion, Mr. Nicolau and Pak Bugo. I think we need to work together with policymakers and politicians, right, to communicate our results so that they can make a good policy for our environment. Perhaps that is our next work. Okay, let me see there is no question from Zoom. Okay, but is there any question from our audience in this room? Please. No? Okay.
So I was just saying that in my class, if I ask my students if there are any questions and no one asks questions, then I will be the one who will be asking questions.
It's like because this after development economics class, right? Some of them. Okay.
So it's either you ask questions or I'll ask questions.
Yes.
Without pressure, right?
No pressure.
Okay, I think this is just a little curiosity on, it was mentioned earlier that a week after the London smoke, there was a excess mortality of 4,000 individuals, and the number was raised to 12,000 in the following year. I was a little curious, is the rise in the excess mortality in the following year was also a part of the domino effect from the London smoke? Or not?
Yes, basically also at the time, this is actually like an interesting one. Basically at the moment, it was very clear that 1 week after, like there was excess mortality of 4,000 individuals. Then basically like during the following year, there was this excess mortality of 12,000 individuals that basically like Wilkins at a recent paper showed that at the past it had been linked to flu. So basically the government at the time it kind of said like, there's this excess mortality, but it's probably linked to flu. And in a very, not very recent, but in a much more, let's say in 2000, published in 2001, they kind of showed that this 12,000 excess mortality was actually not caused by flu, because it didn't correspond to the yearly trends of flu, but it was actually caused by the air pollution. So yeah.
There are any specific criteria, I mean, like, the people, the death are from specific range of age or size?
This I don't know, to be honest. I haven't looked at this. I know what I checked out is like, and that's also why we chose as our primary outcome respiratory health at the beginning. Like most of these deaths were also caused by respiratory health, like 65% of them. I'm not sure if it was any kind of age insight. If I would have to assume something, it's probably like elderly individuals with pre-existing conditions, no? Because if we think it's like respiratory health with people with asthma or COPD or these kind of conditions. But to be honest, like I'm not sure if this data would be available. But let's say that part is more of the motivation of the. Thank you.
Thank you.
Okay. Is there any feedback or enough from you? From other students, maybe? There's questions? Oh, yes.
I will just speak without the microphone.
Yes, please speak without microphone.
Okay, so, first of all, thank you for both Nico and Nico for your presentation. It was really enlightening. I would like to ask a question, but this borders, rather towards my curiosity. As an undergraduate student, I am aware of the issue of climate change, that it is quite important. But through our discussion, it's established that climate change is detrimental to the health of the people. And I want to believe that everyone here advocates for climate change. Again, they believe in the idea that there should be changes to the economy so that pollution could be decreased. And I am under the impression that pollution comes not only from transportation system, but also in industries. My question is, if the world has established that climate change is true and dangerous, then why has there been no visible fundamental change to how businesses operate, or has there been any ongoing attempts towards changing the status quo now? I would like to understand like the current circumstances of the industry, or to the extent of your knowledge, Mr. Nico or Mr. Was there any attempts to actually move towards a better and a healthy industrial system? That's the question.
So I think like there's like for instance, I think that like two factors that can be highlighted. First one, as I was saying, like the problem is that air pollution or pollution in general is very much linked with economic activity. So therefore, there's like this kind of confronted factors. We know economic activity is good for many outcomes. No, it helps countries to develop. It brings well-being, can bring better health systems, it can bring better education. So it's good at very many levels. On the other hand, we know this, let's say, this development, no, this economic activities is creating this externality, that's air pollution, that's very detrimental at many other levels. This is related with the second point, and probably like as econ students, you are familiar with this concept now of public goods and public bads. Air pollution is driven by this economic activity which is very necessary, but additionally, it's a public bad. It's basically if someone's developing an industry, for instance, which could have some positive effects for society, but has very negative ones as well. No? For instance, like this pollution, this air pollution is shared among the rest, while the benefits of this industry are only, let's say, like taken by the producer. This makes it by nature very difficult to tackle these kind of problems, and therefore, like probably the frustration, you know, that you and probably me and everyone in this room and probably everyone who's sensible know shares, or living in a world where we know about climate change, about the harm that it's creating, about maybe even condemning future generations, if not humankind, and not being able to do nothing against it, because really there's this very tricky conjecture. Also, again, I think like on my part, for instance, or on our part, the path that I have chosen, for instance, is research. But I think like in a big way, it also comes to single decisions, you know, trying to do the little we can, no, like trying to take ethical decisions, no, along the path. But I also agree that sometimes that's not possible. I'm the first one who takes many planes every year, knowing that that's very bad for the environment, and I'm sure that many of you also share this bit of grief. So yeah, it's a very tricky one, and I don't think, I'm sorry, there's not like the answer. It's excellent.
Discussion.
No.
Thank you for answering.
Oh, okay. it's tricky. I think it's the comment from, I agree with Nico that we as economists and researchers try to get the evidence based policy, because at some point I know like some people like fatalists here as in Indonesia, looking Indonesia as a fatalist, they cannot change. But I think Indonesia or maybe can change gradually. As well as if we find any evidence, people will understand For example, for example, now they are we discussing about is it electronic vehicle is a good investment for us or not, for example. And then is it palm sustainable? Is it palm industry sustainable for us? Because if we know like in the last 6 months we are producer of palm oil, but we pay for very high price of palm oil. Why is happening? Then one of the part of the forest fire, for example, is part of the because of the palm industry. I do believe that Indonesia can change little by little, but it's not like can drastic change. Cannot push that because as I mentioned, we have a climate skepticism, for example, and also if we think the politicians have the idea of how to get re-elected in the next term, and after they have a very limited time, so that's why one of to boost the economy. In case of Indonesia, first is the coal, the second is palm. So that's why that's the main source of the. Even in Australia, for example, they also have a trouble with the coal second, but they now cut the. I think I heard that they will not using coal anymore. So maybe we are going to that way, but not now. So just be patient. Maybe you can make a small research, and then try to put it in a newspaper, for example, and then keep to make sure that communicate the evidence that Nico maybe and other have found. Then see, this is the cost of you neglect the fact that the pollution and pollution, everything related to climate change is really take consequences in a very high cost for us. So, but it's very long battle. So cannot win it. You better win war than what? We need to not every battle we need to win, but we need to win the war, right?
Is it enough? Yeah, she was my student in statistics class. Okay. For other participants, is there any question or enough? Okay. I think our discussion is true. Okay. Thank you very much, Mr. Nicolau, Mr. Hugo, for your presentation, for your sharing about your knowledge, and we are in our end of our seminar. Please give applause for us. Okay, for the last session, I invite Mr. Nico and Miss Kisha to come to the stage. Thank you. Cool.
So, right, this is like a small token of our appreciation. Yeah, it's hopefully it won't bother your luggage.
No,
Yeah, just,
beautiful.
yeah. All right. So can we just take
1, 2, 3.
all right.
Thank you very much. That's very nice.
Okay, this is the end of our seminar. Thank you for attending our seminar. Announcement from the committee, please fill the link, evaluation link on the screen. It will be shown on the screen. Thank you for your attention and see you on our next seminar.
Even tomorrow, I will
As for the recording, we will upload the seminar in YouTube, and for the materials, we will upload that in our link tree in the G Drive. So just click on our Instagram and there will be a link tree where you can find the link on Google Drive and the link.
Oh, gini.
You all.
Oh, oke. Ya. Please.
There you go. Okay.
So are you working on developing in the immediate health and
Different topics. Now we are going now to Switzerland.
yeah.
We will be actually working on drug tests. Drug tests.
I thought drug is the
No, not that. I used to work on that.
yeah, my friend is in Napoli working on the silicon lab. But anyway,
I know you go. I had a paper. I have a paper in drugs.
Mexico, there is a Mexico.
No, all was in Spain and the
Oh,
we published it about computer. I'm not working so much on this one anymore in topic, but yeah, and to be honest, for me, more than anything. If there's like important data, another mind, one context or another, you know, if it's like
yeah.
So,
You working with the some paper or no?
if I'm working with Giovanni, no.
No.
Giovanni is, yeah, we talked at some stage, we get once an idea that we want to do together, but we never ended up, because we're both very busy. And he's doing very good stuff, he has very good supervisor.
And
Thank you, Yaman. Thank you so much.
yeah, this
Jangan lupa
master
upload.
my supervisor.
Terus administrasi nanti mungkin akan jadi minta-minta.